Hi guys, welcome back to Life Education's podcast. Myself and Caroline here again, and today very excited to say we're with Dr. Jacob Harden, who is one of my idols in the health and fitness rehab world. It's a pleasure to have you here. Very, very happy and honored that you said you would come and join us.
Oh, thank you guys.
You're here. You've just taught a course last weekend that I was lucky to be one of the students on. But before we get to all that, do you want to just introduce yourself generally to anybody who doesn't know you, and just kind of your background and how you ended up doing the Prehab course?
Sure. So my name is Jake Harden, or I guess as a lot of people know me on social media, Dr. Jacob Harden. I am a chiropractor out of Orlando, Florida, over in the States, and have a sports medicine practice over there, and started kind of doing a social media thing, putting out videos online, grew a little bit of an audience with that, and then started teaching on kind of my system, how I think. And that's Prehab 101, which is the course that you took over the weekend.
Yep.
And we brought it out here to Dubai for the first time over the weekend, and headed over to Kuwait next weekend. So it's been a lot of fun being able to do that. And so now I'm kind of just mixing my time between treating patients and teaching and social and being a new dad and all the things that go along with all that. So that's me. Yeah, life, right? Yeah.
Because one of the things that really stands out about you is your social media presence, and I think you've got well over 500,000 followers. But it's not just the content. You're one of the people for me that really stand out at. You're obviously quite tech savvy because your stuff is very well created. So there's the creative side. And I was quite surprised when you said that you do it all yourself. Mm-hmm. So I think that's one thing to make note.
Do you know what? We discuss this a lot because unfortunately there's a lot of people on social media that are either very good at the social media part but not very knowledgeable, and then you have people that are very, very knowledgeable but are not on social media. So you happen to be one of the rare few that actually has combined those two skills and really like pushed it out there, which is really nice to see.
Yeah, I think I'm just a nerd in all aspects of my life.
That's awesome though. That's what we love.
You know, like it's I get into something, I'm like, okay, I'm gonna research that, I'm gonna research this, right? And I do that with healthcare, I do that with tech and cameras, and it's just, I think it's my personality. I have to be the best at everything.
Well, you've done very well.
Yeah. I mean,
try.
I follow all your stuff regularly and get involved and read the comments and see what's going on. So it was great that you came over here, because I remember I was looking at the course that you do in Dublin where my parents are living, and I was considering flying back because I didn't think you'd actually come out to a place like this to teach people like us. But thankfully you did. I jumped on the course. I think the Max and Eagle guys did it, so shout out to them for putting up the show.
That was an amazing gym. Like that was just one of the most beautiful facilities that I've been in.
Yeah, it's a brand new place out in Maidan. I don't know if it's even got the doors open yet, but it's it is. It's a stunning, massive open space. So much possibility in there. But coming back to the rehab stuff, so a lot of the stuff that you spoke about at the weekend was kind of about the psychology behind rehab, kind of how you would talk to your patients, the languages that they use, the misconceptions that they might have, their own interpretation of what maybe back pain might be. Because remember we talked a lot about, like, people don't know what's going on in their back. So the injury that they get, the pain that they get, the language that people use can always be misinterpreted as being more catastrophizing rather than an actual idea of what's going on.
Yeah, and so I guess the analogy I like to use is paper cuts. So when you get a paper cut, it obviously there's
hurts
so bad, right? It hurts so bad, and there's obvious damage there, but you have experience with it and you know what's going to happen, you know it's going to heal. You know, if you just throw a Band-Aid over it, you move on with your day and you don't worry about it, right? You just let it be. But with back pain, you can't see it. You don't know what it is. You may have had a family member that I had back pain and I was never the same, or my back has never been the same since, and I think I'm going to need surgery for this. And you hear all the stories. So it's a lack of clarity. Like there's a lack of clarity with these other pains that whenever you don't know what it is, makes it worse than what it is. And that often leads to people what we call catastrophizing their pain, which is made up of three things, which is helplessness, magnification, and rumination. So magnification, making it bigger than what it is. Rumination, you are just always thinking about it. Like, it's always on your mind. And then helplessness, no one can, like, I just don't think it can get better.
I've tried everyone. No one knows what they're doing, or no one can help me. I've gone to see all of these people. Yeah, I hear that stuff as well. I understand what you mean.
Yeah, and we see that when people do that, they get worse outcomes. They have longer disability. They are in more pain for longer. It's one of the biggest predictive factors of pain going from an acute state to more of a chronic state, and it just sticking with people. So we really try and dive into that aspect of it with people to, not everyone needs to be seeing a psychologist by any means, but a little reassurance of saying you're going to be okay goes a long way. I
also think as well that when you do get back pain and then you go see your doctor, and then your doctor refers you to either an orthopedic surgeon or somebody like that, it's very easy to go down that medical machine that kind of encapsulates you and goes, oh, we're going to have surgery because this is this bad and this bad and this bad. So I think as well the industry itself has led to take people on this journey, and sometimes they don't understand that there are other routes to that. Is that also your experience?
Yeah, there's definitely whenever people get referred straight away over to that kind of thing, then they might go down a path of, well, we need to get the image and we need to see what the scan says, and then they see the scan and the scan shows them something, and now you have maybe something to link your pain to, whether it's actually linked to your pain or not. They hang on it, and it's getting better. I really think it's getting better, and that people are recommending conservative care more than at least as a first line before surgery now, versus just saying we should cut. But there's definitely still like an overutilization of imaging. People actually have worse outcomes and longer disability whenever they get an image for back pain versus those who don't.
Really, yeah.
Yeah, and so it's just one of those things where, like, when you see it, you see a problem here. We see that those people are seeing their doctor more often. They have higher medical costs. They have disability for longer. So their outcomes just are worse when seeing that. So now the current recommendations are to only get an image whenever you suspect that there's something very, very, very serious, a red flag. So infections, cancers, fractures, those kind of things. Or you really need to look at something that might have like neurological symptoms.
Yeah, I think we talked about that briefly, didn't we? The kind of the cauda equina syndrome. That's one of the ones. A lot of those shooting pains, nervous system issues. That's the one to go straight for a scan. Because I always find, and we spoke briefly again at the weekend, I always find when I get a scan, someone comes in with a report, it's okay, they're fixated on this, we must address this. And going through it with people firstly puts them at ease that someone's addressing this, someone is taking them through the process of, okay, what does this mean? This is anatomical language I don't understand. And for me personally, I always tend to focus on more of the positives. That's all right, don't worry. Do you need to get that?
No.
Okay.
It's most likely an advertisement that I think is part of. I should go turn it on silent.
No, that's all right. It's okay. For anybody listening, the mics won't pick that up. There's a phone ringing over there.
It's okay. You can cut it all out.
Yeah,
we can talk rubbish right now.
It'll be fine. So what were we talking about? I can't remember. Going through the scan. I'll sit and go, okay, so this is what's happening. This is what I've been told. So let's focus on all of the positives. Let's go through the 12 positive things, that there's no joint effusion, there's no problem here, the structure looks good. Okay, we've got this one thing here, but we'll fix that. We'll look at that, we'll address that, we'll see how you move. And it tends to put people at ease just by addressing their concerns. You know, And you can't change what the scan says. It can't change what it is by words,
But it can definitely change how you think about yourself. Like, I'll give you an example. Recently, I had my spine and my pelvis scanned, and I was told I needed to go have surgery again, that I had non-union in my pelvis and non-union in my spine. And then all of my friends and family around me was like, you can't do this, you can't walk, you can't run, you shouldn't be doing this. And I was like, I've been like this for 3 years. Like, I'm fine. I'm just going to keep doing it. But the thing is you do have these moments when you get those scans and you look at everything and you're like, oh shit, maybe I shouldn't do anything. Maybe like that's why it hasn't healed, or maybe I should just be in bed. So it really takes like a change in mindset, and to be quite strong in your mind to be able to go, well, actually, no, I need to do the opposite of what everyone's recommending. Right? Maybe?
You have to work within your own capabilities.
Very well said there.
Like, you have to work within your own capabilities, and if the last 3 years have shown you that your capabilities are that you can do this, and nothing takes a year to just come on. Like, what disease, what musculoskeletal disease just it comes on like that? That would kind of negate the whole adaptive process of the body. So your body's kind of figured out a way to function.
Yeah, my body's doing well.
It's doing pretty well. So if now maybe that non-union and all that stuff means that you have to be a little bit more cautious with how quickly you increase your activity over if it was everything looked perfect. And that's kind of how I view scans to people too. It's like, yeah, this is here. Sure, we acknowledge it. It's real. And so maybe that means you need to be a bit more cautious with how quickly we increase our activity levels over someone who had a perfect picture, So, but it doesn't mean that you just should just lay up and die, right? Like, just stop. No, that's not the option. So,
so I'm interested, just to interject there, because I had a thought. I'm interested to hear your whole take on rehab and how you view that whole process and how you go through that with people.
Well, I try and keep it fairly simple in the general framework. So I recognize that the body is incredibly complex, and pain is incredibly complex. And I, in no way, can probably account for all the different multitudes of factors that are going on in something as complex as the human body. So I think it kind of necessitates more of a simplistic approach to what you're doing. So the way I view everything is, you have a certain level of function right now, okay? You have a certain level of function that you need or want to have over here. What do we need to do to move from point A to point B? Okay, so if we need to restore some range of motion for you, or maybe you need to be a bit stronger, maybe you need to change your mindset towards how you're feeling, or we just need to calm something down, we try and get into what's the next blockage, what's the next wall that we need to climb, what's the next hurdle we need to jump over to get to the next step. And then we're just going to keep taking those steps one at a time until you're eventually over here. And to me, that's kind of what rehab is. It's just a preparation process, just the same as fitness and training and all that is a preparation process. So if somebody, say, has a running injury, then do we need to necessarily have them stop running and just do a bunch of clamshells and glute work or whatever? Some people maybe yes. Other people might just need to back their running down to a tolerable level and then say, okay, now run here, because it's the same, because this level is what you can currently do, and we'll gradually bump your thresholds up in order to get you back to where you want to go. Not everything is caused by weakness, tightness, whatever. Sometimes it's just things are sensitive and we need to calm it down and then build it back up off the base.
When you say calm it down, are you referring to the nervous system?
Yeah, calm down. Yeah, basically. Okay. So when we look at pain, it's much more likely, or a better description of pain is not necessarily that it's an indicator of damage within the body. Sometimes it is, but that it's more of a perception of threat coming from the body. So think about how you feel fatigued after a workout. Fatigue is a negative subjective sensation. So if you never felt fatigued, you could just literally stress your body for days on end and, run every tissue in your body into the ground. But the fact that you feel fatigued makes you stop. It's protective, right? So your fatigue levels are protective of you. Pain is along that same, kind of line. It's meant to kind of be protective of you.
So it's like it's looking after you.
Yeah, listen
Like,
to your body is a
hey.
good thing to do.
I think if instructors and trainers, firstly, but also the population as a whole, if we can get a better understanding of pain, it's going to make people's anxiety towards pain much less, and it's going to, I think, shorten the time. This is purely just my own opinion, but I've always found if I can explain to somebody what pain is, and that it's a difference between the structural damage and the nervous system sending info to the brain, and the brain saying, all right, we're not happy with that, we're going to make this area hurt. If people understand that's like sitting at a desk all day for 8 hours, they've not suddenly just gone and popped their back, or they've not suddenly just gone and just spasmed up their spine. It's just the body's not been able to receive the info from that, or the brain's not been able to receive the info from that area of the body accurately enough to reassure itself that there's no threat, so it begins to manifest this little bit of a dull ache. And then that feeds into their mental memory bank of what happened when I've hurt my back 2 years ago. Is this going to happen again? Anxiety goes up, stress goes up, and then that pain becomes a little bit worse.
Yeah, everything goes into that. So, if you're sitting at your desk for 8 hours straight and you never move, you're likely going to feel an ache. Like we've all taken a long plane flight and felt not so hot at the end of it, right? So, but the thing is, like, if you sat up perfectly straight, shoulders back, everything, like, and tried to be perfectly still for 8 hours straight, yeah, you're still going to hurt.
Yeah.
Right? So it doesn't even necessarily mean that it's threatening. It just means that it's trying to tell you something. And it might just be like, hey, move. Like,
Yeah, get up.
Wake up.
Mm-hmm.
Yeah.
Like, do something, right? And this is where it's just like variability is better than stagnation, right? And just trying to move and keep yourself comfortable and just be a little bit, be a little bit different in how you're moving here and there. Like, that helps.
Yeah, I think one of the things you said as well, the slouching position it's not a position to be avoided.
It's a resting position.
Yeah, so you can adopt a slouching position and not have to worry about your back breaking.
Oh, for sure.
Yeah.
Yeah. So I bring that up in the courses typically because I see a lot of athletes, and my athletes, they've read about posture and everything, and they're always trying to sit up super nice and tall because, they want to maximize their efficiency as much as possible. And I talk about it in that this is a very active position. You must be engaging a lot of musculature in order to hold this position.
When you sit up straight.
When you sit up straight, right? You can just feel your back working, right? And so the common thought is, oh, well, like, you need your muscles active. You need your muscles active. And I'm like, well, would you work out all day? Would you want to be active all day and never rest? Like, we should value rest. Like, there's a reason your body goes
to
here.
sleep.
Yeah, there's a reason your body goes to sleep. There's a reason you sit down. There's a reason you want to get off your feet. There's a reason you slouch. It's rest, right? And just as we should be prioritizing activity, we should be prioritizing rest. So if we have that person who is sitting for 3 hours straight or an 8-hour work day and then doesn't work out at all, and they never go for a walk, they come home and they lay on their couch, and then they go to sleep, and then they get up and they sit in their car, and they're just literally doing that day in, day out, maybe we should promote more activity. Maybe we should promote sitting up straight a little bit more, versus the person who's just active. Maybe we should be promoting a little bit more rest and just say, hey, chill out. Like, if you're sitting up straight all day, please slouch.
Yeah,
if you're slouching all day, please sit up.
I was going to say to you, I remember we talked about this briefly, that some of the studies about athletes and recovery, and just by increasing their sleep to, say, from 6 to 8 hours, the improvements that they get in their performance. And then again, showing how important it is to have recovery days and to have ample sleep, in terms of having a multifaceted human that also is doing activity and rest and recovery.
Right. More is not better.
Yeah.
More is only better whenever you can recover from more. Right. So we see.
You need to tell her that sometimes.
Yeah.
That's so true.
Like typically you look at it and like more training leads to more results. More weight leads to more results. More yada, yada, yada leads to more results. But only if the system has the recovery capabilities to withstand it. So when we look at exercise, there's a dose response effect to where at some point it's going up, but then at some point it starts to kind of tail off. You're not getting as much result as the work you're putting in, or eventually you're getting less of a result versus you get more if you just did less work, because now you're literally fighting your body's own recovery and you're like digging yourself into a hole to where it's doing more harm than good. So our goal is to get the most result, right? The most result in the most efficient way, not just do more.
Mm.
And do you think this day is the right time to recommend someone couch day, do nothing, put your feet up, put Netflix on, start episode 1 and go for it, do nothing till tomorrow?
Oh, heck yeah.
Yeah?
Yeah, I think there's a lot of value in stillness, right? So I'm all about individuality. You have to look at the person you're talking to, the person you're working with, to where, let's say you, and you're very, very active.
Uh-oh.
Yeah, right? So I'm getting that vibe, right? Then you're probably that person that having that day off your feet is probably a good thing.
Yeah, I do watch like a whole series on Netflix.
Yeah, but that's the day after you've just climbed a mountain and you're in pain. That's not the day after like you've got your minimum dose just right and your maximum dose just under, and you've gone, I will do the sensible thing and sit.
Yeah. I know I'm a little bit crazy. I like to push my boundaries. I like to know where they are. And
they're
when
way back there behind you.
Yeah. When I get there, then I know. Like,
but there's nothing wrong with that either.
Yeah. So I have a very different philosophy, and I don't recommend other people ever listen to me at all. But I don't like to take any painkillers or anything like that. And I vowed never to do that once I left hospital. And I do that because I understand where my limitations are. And then when I get there, I can like mentally measure, oh, okay, well, last time I did this, I could only run 3Ks. And after 3Ks, I got into a lot of pain. So then I teeter at 3Ks for a while. And then I tried, 5. And then I'm like, oh, no, that was way too much. But so I like to explore those boundaries and then constantly push them. But that's just me.
But you have the advantage of, like, you have an education in this. You have a foundation, and you know your body, you know your systems, you know your pathways, you know the nervous system. For people who don't know these things, they're shooting into the dark way more than you are, when you're starting those exercises.
Yeah, and this is why it's so important to listen to people like you and your experience of rehab.
Well, I think you can do that because, one, you're not afraid of pain. And I think that you accept that, like just talking to you, like you have the mindset of, okay, that's there. That is my boundary. I get that. I accept that. And I'm obviously just not ready for that quite yet. So I'm going to teeter back here a little bit, and then we'll try again.
Yeah.
Versus some people would see that and they run into that pain because they went and they jumped their activity level so much. And then they'd be like, whoa, what the heck's wrong with me? And they might be a little bit more afraid of that feeling that they got. Right. And it's just, so you have to look at the person that, that's doing this. And that's why I say, I think it's okay for you to kind of push those boundaries and see where they're at. I think that's probably better to go from, 3 to 3.5 to 4 to 4.5 to 5 versus 3 to 5.
Or 3 to 18.
Yeah, that's probably a better idea. And it's what I would recommend.
On record.
Yeah, that's the best recommendation right there. But but if you are that person, I think sometimes, like I was telling you, I think on the way in, was sometimes you have to see the limit to know where the boundary is. So sometimes you have to kind of get there and you have to experience it, and you need to say, okay, there it is. I get it. There it is. But you have to have the personality type to say, yep, there it is. Okay. And it's just,
I'm here.
It just is what it is.
Yeah.
And you just nonchalantly let it go, versus hanging on that and saying, well, why can't I do that yet? I should be able to do that yet. I'm supposed to be here right now, and now I feel worse about myself, and now I feel more broken than I ever did before. You say, nope, that's just my next goal. There I am. and that type of person can push their boundary, see it, back away from it if they're not quite ready for it yet, and then begin the journey towards it. But that's how you have to approach that.
And that's that recovery mindset, isn't it, where you can accept where you are,
Right.
as opposed to the injury mindset where you experience that negative experience and that's suddenly your new doom and gloom, and you can't beat that.
Yeah, maybe before when we were off air, you were talking about that mindset and the differences, and I think you mentioned a story that you had.
Yes. So injury and recovery mindset is something that I kind of just termed to kind of think about how I just see what all this whole psychological side of rehab is really coming down to. And so an injury mindset to me is that you're focused completely on all the things that you can't do. Like, woe is me, this is what I can't do, I'm so broken, why can't I do this? You're always focused on your pain, you're always focused on your injury, and it never lets you move forward, right? It's like, why am I so injured? A recovery mindset on the flip side of that is an acceptance of where you are and say, this is my starting point, here it is. I know I can't do everything I want to do right now, but I'm going to but look at what all the things I can do still. Like, so, and I'll do that with my patients, is that I will have them make a list of all the things they can't do right now due to their injury, but all the things they can do as well. And then we look at it and we're like, look at how much longer that second list is. And it just kind of like makes that switch of, wow, you know what? Like, I'm not as broken as I thought I was. Right. And so then you're a little bit more apt to start pushing forward and say, all right, I can still do all this. I'm going to do all this, and I'm just going to start taking my next step forward. So it is an acknowledgement of your injury. It's an acknowledgement of, I'm not 100% right now, but I'm not going to let that cripple me. I'm not going to let that paralyze me. I'm going to move forward off of this, because what is my other option? Like, what's the other option other than try and get better, right? And that's really what it's all about, is, are we promoting something that fixates people on all the things that are wrong with them? Are we fixating on all the things that are good about you, kind of like you do with your, reading reports? Here's all these good things, right? Oh yeah, here's this thing, and we're gonna work towards that. We're gonna work on that, right? That is what we're trying to promote here. Is, here's all the positives, right? Not, you got flat feet and you have an internally rotated knee and your posture sucks, and all this must be the reason that you have pain, right? Except probably not. It's probably that you've lived with this body for a long time. Maybe you just increase your activity a little bit faster than you should have. Things hurt a little bit right now, and we need to maybe you need to be a little stronger. Maybe you need to work a little bit on it, but you're going to be able to still live in the body that you have and do all the things you want to do.
Yeah.
How do we get there?
Yeah, it is so important, isn't it? The mindset. Like, from your experience, have you seen people who you may not have expected to recover because of powerful mindset, or the flip side? Have you seen it the other way?
I've seen both.
Yeah.
I go into every patient encounter expecting everyone to recover. Like, I have to have that. If I go into it expecting someone to not get better, then like, who am I to be helping you? Right? Like, that's how I feel. So I'm always going into it thinking, you have the ability to do this. You can do this.
And you know what's so powerful about what you just said just then is that they do. They really do. They have the power to do that. And
absolutely.
They can totally heal. Like, their body has all of the right mechanisms and the tools and the processes and, so much more to be able to actually fix that and heal themselves. They just need some guidance sometimes.
Yeah. I mean, I don't want to sit here and say like, oh, you can think your pain away. Like, that's not always how it works. Like,
that's true, but there is some powerful
definitely
literature
there. It's definitely a powerful way to go about it. Like, you can think your way into knee pain. You're not going to think your way into tearing your ACL. Right.
Yeah.
So there's definitely effects, and then there's a limitation probably to that, but you're going to be much better off taking that positivity approach to it. And so I've seen it both ways. I've seen people that are just super, super positive towards everything, and they're feeling better in 2 weeks. Like, they're just, all of a sudden, they're just feeling great. I've seen people that, they don't feel 100% healed coming out of their first session with me, but they feel better coming out of that session, not because we did anything special to try and reduce their pain. We didn't put a heat pack on them. We didn't put them on stim or anything like that, but we provided them clarity that said, hey, guess what? You're doing great because we got no infections here. Nothing's fractured. You don't have cancer. Things hurt a little bit, and we're going to be able to give you some exercises to start working forward. And it's like, oh, wow. I have a path. I have something to go for here, because when you go to your doctor, you don't go to your doctor to walk out of the office feeling better. You actually don't. You go to your doctor to get your prescription and get clarity on what you have going on. You go there to figure out what it is, make sure it's nothing super bad, then get your prescription so that you can begin the process of healing. And that's what we do in rehab too. So I've adopted that kind of same mindset towards things and that same approach, in that we're there to provide you with clarity on, this is what's going on, this is what's not going on, which is huge too, to just remove a lot of that, because pain's scary, right? It's supposed to be scary. It wakes you up.
That's the operative word, though. It's supposed to be scary. It doesn't always have to be. And I think the more you understand it, and the more you can understand the process of it, I think the less daunting it can become.
Right.
It's, interesting.
Right. So as a lot of my patients walk out the door, let's say they're on we measure their pain on a 0 to 10 scale. So, if they come in at a 6, maybe they walk out at a 4 simply because they had clarity on what their condition was, right? So maybe they're just processing it a bit differently, thinking about it a bit differently, and they're like, you see it just
A
drop
change.
the weight off the shoulders.
Yeah, it's a change.
So I've seen that. I see that a lot, because that's what I actively try and push, and I talk to my patients a lot. I've also seen the other side of things where I can't get through to everybody. I can't help somebody because maybe I wasn't skilled enough in what they had going on, or maybe they needed more help from a psychological professional, and my skill set just wasn't there for that person. And they were so fixated on the injury, and they were so fixated on the pain and all the things they couldn't do.
Yeah.
And anytime they felt an ache, they felt like it was a setback. Anytime they felt some pain, they felt like they did something wrong, or they broke themselves further, and they was like, nope, it's never going to get better. It just won't. I've seen that, and then they didn't get better.
Yeah, I've had a very exactly the same experience plenty of times, but one lady in particular, I remember she was a runner, an endurance runner, and she used to run 15, 20K in her training. She was the coach of the local running club, and when she would come to the gym, she would continuously tell me what her doctor told her she couldn't do with her knee, and that is to flex it beyond a certain degree. And she wouldn't, she wanted to do a bunch of stuff like a Bosu thing, but she wouldn't jump onto the Bosu because, she was like, no, that will hurt my knee. And I was like, okay, well, you understand that when you run 15, 20K pain-free, you're putting way more force through the tissues than just from here to here. And she's like, nah, but that will make my knee grumbly. And I was like, okay, fine. So what do you mean grumbly? And she's like, oh, my knee will grumble. And I was like, okay, what does grumble mean? Because I don't know that word. I didn't want to embarrass her, but I was like, what does it mean? And she got stifled on her own language, and she had to really think. She's like, look, my knee wouldn't like that. It's like, okay, we won't do it. We'll do something else. And then one of the other days we were doing an upper body session, and I had her in when you put a band from the pull-up bar, and she gets into the band, she did a bunch of pull-ups with her legs straight, her foot in the band. And then all of a sudden, she kind of lost her center of balance, and her foot stayed in the elastic, but her knee shot up. And her knee, if anyone knows, you're hanging, and her knee was all the way up at her chest. Yeah. And her foot was caught in the stirrup of the band. And I walked over to her to help her, and I was like, look at your knee. And she's like, what? And I was like, look how much your knee is bent. I was like, is that hurting? She's like, no. And she was also like, get me down. Yeah. But I was like, look, that's great, isn't it? Look, your knee's not hurting. And I made her pause, and I kind of consciously let her stay there for a little bit longer than I maybe should have, but I knew she wasn't going to fall, because I wanted her just to see, your knee is okay. Like your knee, it is allowed bend. If you let it bend, if you just let it get there. But I felt like because she was in charge of the running club, she wasn't quite where she used to be in her professional, in her athletic career. She was holding on to this because this gave her a reason almost to not be the coach who was winning the races or who's
See,
doing.
this is what we discussed before about sometimes being attached,
Yeah.
like to your own limitations, and then using that as, oh, okay, like I'm injured, I can't do this, and that's the reason why you don't move forward, or
Yeah.
the reason that you don't progress, as opposed to making it the reason that you do.
Yeah.
Does that make sense?
Yeah, for sure. And there was the ways where I had to almost not trick her, but I'm sure you might have come across this before, where you have someone who complains of back pain or knee pain, and they can't do a squat. I was like, okay, just have a seat there for me, and they sit down. You're like, gotcha, and they're like, what? And I'm like, look, you just did. I'm like, what? And like, you just went from there to there, whereas a second ago you couldn't squat. So they're like, okay, I did do that, didn't I? Okay.
Yeah, we call that reconceptualizing the movement.
Yeah.
So we use that with chronic pain patients a lot, because in chronic pain, you actually have neurological changes that happen to where, rather than, say, an acute injury, you have signals coming up from the tissues to the brain, processed pain output. So in more of a chronic situation, you don't necessarily have to have those nociceptive signals coming from the tissues anymore to feel pain. It is what we call more of a top-down approach, to where movements can actually get linked to the pain sensation. So flexing your back, chronic back pain, right? Just bending over and picking something up, touching my toes. Anytime I would flex my back, I would feel back pain. So we can kind of reconceptualize that. So say somebody has like chronic shoulder pain and they can't raise their arm up without it hurting, you have them put their hand on a doorway and then say, okay, keep your hand there, but I want you to lunge. And so their arm naturally goes overhead, but they did it via doing a lunge, right? So they didn't actually raise their arm up; it just happened. And then you kind of say, okay, let's do that a bunch of times, and you like point it out to them. You let them know what's happening. Like, look what you can do.
Yeah.
Look what you can do. Or, okay, just how about instead of squatting, we just sit to a chair and stand back up, right? And you have them do it a few times and make sure that they're like, oh yeah, I'm fine with that. Why shouldn't I be fine with that? I'm like, because that's a squat.
Yeah.
That's just a shorter range of motion. And this is the value of progression, right? So rather than just thinking, oh, well, you have to squat, right? So a squat just means like, obviously my hips have to go below my knees and I have to be holding a weight or something. It's like, no, maybe it's just you sit down to a chair and stand back up a few times. And it's doing the same general thing. But guess what? Now you have a next baby step, which is sit a little further down, or hold a little 5-pound weight with you as you do that, or hold a book at home. It's like, now you're offering the path, right?
Yeah.
And it starts with just showing them where was the starting point. I think the getting started is the hardest part for most people.
Yeah, I find what works very well for people who squat, they believe they cannot squat, they can't move down. What will they ever be able to do? Get them that kind of biomechanical difference where they go into a TRX, lean back, and then squat. And suddenly they've looked at their knee in front of their own eyes, bend all the way down, and they're like, what? How has that happened? I was like, well, we've changed a few things, but like trust, we can put some force through this knee. You're not stuck. You haven't completely lost the use of the knee. And then for me, that gets their trust almost a little bit more, and little things like that they begin to build a trust. So then they begin to let go, and then they begin to just go with me on a few, okay, let's just try a lunge, and I want you just to stop at the depth that you feel the pain. Whereas the first couple of lunges when the assessment, it's like, nah, it's right there at the top. Whereas now they're willing to just go a little bit lower and a little bit lower, and you can begin to work into people's ranges that way.
Sorry to interrupt you. I just had a question. I wanted to know, do you think that the hardest place for let me say that again. The hardest thing for people is the start because they don't know the path and they don't understand and they lack clarity, or are there other facets of that make it difficult for people to find that?
It's probably a mix of both things. It's probably a mix of factors in that. I think a lot of people just don't know where the path is. So whether that is believing that they shouldn't do something, they've been told they just shouldn't do something, and they've never been told like how to modify the variables around, so let's say, an exercise. So all they know is this exercise is bad for me, right? This is bad for my knee. And it's a very black and white view of everything. And they maybe weren't told that, well, you could modify the sets, the reps, the weight you're using, the technique you're using, the speed you're moving at, the range of motion you go through. And all of this literally changes the load that we're placing on that knee. And having a black and white viewpoint of saying this is bad is kind of worthless, honestly, without some sort of baseline measure of what you could handle in the first place. So finding that first thing they can do is very powerful.
Like sitting down on a chair, standing up.
Yeah. And I've taken people to, let's say that they can't even sit down to the chair, and we have them just hip hinge back to a wall, right? So the hip hinge back to the wall gives you a little bit of knee bend, but it's the same starting motion of the squat, right? So then we can say, all right, that's where we're starting, and we're just going to start right there, and then we'll maybe sit back to the wall and slide down a little bit, right? And it's just like, okay, how many steps in between am I going to have to take? I'm going to take whatever I have to. But just figuring that out is the hardest part. And I think a lot of people have just been told, this is it, this is what you can't do. So don't do that.
That's really true. A lot of people are told that.
Do you think labels need to be reconsidered? We spoke on the course about shoulder impingements and how you tell somebody got a shoulder impingement, they become fixated on that new diagnosis.
Right. So if we're going to apply, I don't like labels in general because I think people just naturally fixate on labels. I mean, we see this in all facets of life, not just pain. We see it professionally and everything. People like titles. So if you're diagnosed with impingement, especially, this is a big one because the understanding behind it is that the tendon is getting caught on the bone, or something's getting caught on the bone in here. So if you have this thought that something's caught on the bone, then the only real thing that makes sense would be, okay, well, I probably should get rid of the bone. Something that needs to change. Yet that's not what's going on, because your shoulder impinges every time you bring your arm up. That's normal movement. And we have made pathology out of normalcy for a long time. And so if we change the label, or if we obliterate the label, and we just tell people, this is functionally what you can't do right now, but here's what we're going to do about that, then I think you give a lot more clarity to things, even though people really like their diagnosis, they want that diagnosis. But so we were talking about, last year was kind of the year that shoulder impingement kind of got blown out of the water, because 2 studies came out that looked at subacromial decompression surgery versus placebo. So they took they took 2 groups. One got the decompression, the other just got arthroscopy. So they just put them all the same stuff, put the scope in, pulled the scope out, and then said, oh yeah, surgery went great. They got the same results.
Yeah, do you know what? Actually, we've spoken about this a lot, because this book blew my mind. Joe Dispenza, Evolve Your Brain, and then the You Are the Placebo. So a friend of mine bought it for me, gave it to me, and my husband read it to me in the hospital. And that book just made me change the way that I thought about things, because there were examples of exactly what you just spoke about, but in different scenarios with cancer patients, and then with terminally ill patients, and with knee surgery, giving people, pretend surgeries, cutting them open and not really doing anything, stitching them back up, and really having exactly the same results. Beneficial results, because these people thought that they had surgery, which again kind of goes to show how powerful your mind is in that whole process.
Right. So I ask a question. It's the question I opened day 2 of the course with, which he knows. What's the difference between disease and illness? Okay.
Oh, I don't know. Can I cheat? Can you tell me the answer?
So disease is a pathological process. It has a known cause, a known effect. illness is the subjective state of being unwell. Okay? So are we treating disease or are we treating illness? More often than not, we're trying to treat the illness for the person. Now, sometimes you must treat the disease in order to treat the illness. Okay? And
Can you give me an example of this so I can understand it a little bit better?
so, so let's say that you have, let's just say that you have some sort of bacterial infection. That's the disease, right? You can be much more ill, like you can feel a lot worse than just what the infection is causing. Okay? So bedside manner is not necessarily treating disease, but it makes you feel better to have that doctor there who cares. Okay? It makes you feel better to have that warm, attentive team who comes and checks on you. That's all treating the illness, not necessarily affecting the disease. Okay? Because that's what you need your medications for, and you're going to need to treat the disease in order to fully heal the illness in this case. But in some cases, you wouldn't need to. So let's take the example of disc bulges or disc herniations. You are more so in the minority if you don't have a disc bulge in your back. Like, it's that common. So a lot of people see these things on their MRIs or their scans, and they're said, like, that's your pathology. Okay, that's your disease. Okay, and I'll use the word pathology here. So they link that then to the back pain. And it's this, they try and they're often made a 1-to-1 ratio. My pathology is the cause of all of my pain. Okay? And I must get rid of this in order to fix this. Yet it's not how it works, because let's say we're all probably in our 30s. 40% of us have disc bulges in our back and have no pain or limitation. Okay? 40% of us in the asymptomatic population have that same pathology. That doesn't need to change in order for you to be well again. What needs to happen is you need to figure out your starting point and move forward off of that. And what it really brings into question is, does that pathology play into your pain at all? We don't know, right? Maybe it plays into it a little bit. Maybe it plays into it not at all. Maybe there was nothing about that, and it's just completely incidental that we saw it. So we just need to not make these 1-to-1 relationships.
So my
between
pain
all
is
this.
because of my disc bulge.
Right.
Yeah.
Right. So think of it this way. We would say that about 10% of the world's population is left-handed. Okay? So they're abnormal. They're the weird ones. Okay? Us righties, we're the normal ones over here. Okay?
There's 6 people in my family. 3 are left-handed and 3 are right-handed.
Really?
Yeah. So I got weirdos. In my
So,
family.
yeah, you got weirdos in your family. My sister's left-handed. So
I'm right-handed, so I'm normal.
Yeah. So what are you?
Right-handed.
Right,
yeah.
right. So we wouldn't say that, oh, well, you have shoulder pain or you have tennis elbow. Oh, it's because you're left-handed. Because that's your abnormality. We don't say that, but that's actually a much more common abnormality to be left-handed than it is to have a disc bulge in your back.
Oh, wow. Okay.
Right? But we
Yeah.
don't make the association of, well, because you're left-handed is why you have shoulder pain, or because you're left-handed is why you have your
Okay,
tennis elbow.
so I have a question.
Yeah.
Then what is the manifestation of pain for a lot of people if it's not a particular injury? So say we scanned someone's entire body. Say we scanned Keith and we found 50 things wrong with him.
Which we probably would.
Yeah. So we'd find a disc bulge, we'd find something else, we'd find shoulder impingement, and he only had pain in one area. Why?
I don't know.
Are there any suspicions?
There's a lot of suspicions and there's a lot of potential reasons. That's why we call it a multifactorial process.
So what are some of the other facets that might lead to that?
So we call this the biopsychosocial approach. So biology, psychology, and then the social components, because they all play into everything and they all have interrelationships between each other and to how they're going to affect someone's pain. So from a biological perspective, one of the biggest things you might look for is a change in activity level. Did he do something different? Because he's had this, let's say he's had this body, yeah, he had this body yesterday and he had no pain. He had same body today and he has the pain. What changed? So if we're going to link it to, say, the disc bulge, we need to say, all right, that disc bulge wasn't there yesterday. It's here today.
Mm-hmm.
Okay? Otherwise, it can't be the sole cause of the pain, not on its own, right? So what did he do differently? Did he go out and did he run a marathon yesterday? Did he hit a PR in the gym yesterday? Did he up his training volume? Something crazy? Was he in a car accident yesterday? Like, what changed between point A, point B that maybe like set this in?
Mm-hmm.
Maybe we don't know. Okay, but that's might be the first thing we might look for.
And what if nothing changed?
And that happens.
Yeah.
That happens. Or typically something will, but sometimes things can be a little cumulative. We might look back to more of I would say, I'm not going to say like it built up over a year or something like that, like we might look back a few weeks or something and say like what happened there. But
sorry to interrupt you. If it wasn't the biological aspect, could you then look at the others?
Exactly. So so then we have to kind of think about, okay, well, has your work hours increased? Are you more stressed lately? Did you have a fight with your significant other?
Mm-hmm.
Have your kids not been sleeping? Like, have you been staying up late? Like, all these things start to go into it too, that's the psychological side of things.
Sure.
Right? And sometimes, you feel stuff randomly. Like you wake up one day, your knee kind of aches whenever you go for a walk.
Yeah.
Like I had that last night. Like my outer side of my left ankle was just like achy when I got into bed last night.
And because I get the same thing, and I'm always like, like I didn't mention this, but I'm on the Saturday on the course. At some point in the middle of the afternoon, my back started to just before we done the practical stuff, my back started to ache, and I was like, what is this? And I've found in my, like when I was a postgrad student, I was trying to analyze everything. I was like, hey, maybe what if I did this, I did this, I did this, I did this. Now I'm just like, damn it, this is gonna be painful for a day.
Yeah.
And I just have to wake up tomorrow and hope it's gone.
And sometimes, you just move it around. You're like, oh, I wonder if I can move that around and see if it'll just kind of lessen or whatever, and maybe it does, maybe it doesn't. But sometimes stuff just comes on randomly.
Yeah.
Like, so for my ankle, it's probably because I went and I walked like 7,000 steps in flip-flops yesterday, which, I normally walk 10,000 steps a day, but I'm normally doing it like in my Metcons. I'm not usually in flip-flops. So it's like a change in shoe. And
you're also in a changing climate.
And I'm in a change of environment.
Mm-hmm.
And my circadian rhythms are just completely flipped because I'm 15 hours ahead over here. So like these are different factors that might play into it. And I just got done teaching for 16 hours and, yada, yada, yada. We start to like line all these things up and say, yeah, all that might have been a part of your onset. Might have been a part of your onset, because we can't say for sure what it was, but we start to kind of develop the story about what everything that could have possibly played into it.
So that's the psychological component. Just to clarify for people, there's the biological, the psychological, and what was the last
social
one? Okay.
So social is an interesting one in that, social comes into like your relationships. Okay, so like I said, like maybe you had a fight with your wife, maybe you had a fight with your husband, maybe your kids weren't sleeping, maybe your boss is a dick, it's just like totally stressing you out. So you see that interaction of like this social relationship led to a psychological thing, which then made me more stressed out and then manifested something biological over here. Sometimes it's whenever you're already feeling pain and you don't feel like you have any social support around you, and you feel like, so like whenever all your family's saying, no, don't do that, you can't do that, that's the social side of this, because you almost feel alone. Like, am I doing this on my own? Am I having to go through this to get like, no one gets it. I don't have anyone I can talk to about this because no one understands what I'm trying to go through. And one thing that I think goes into the social side of things too is social media these days. What have you read? What have you what video did you watch recently? Maybe you just watched a video on how your pelvic tilt causes your back pain, or how sitting's bad for you. Maybe you heard sitting is the new smoking, which is a phrase that gets thrown around way too often now. But then you have a desk job and you're using that to provide for your family, and you can't get up because you don't get the option to take frequent breaks, and you can't take a walk during lunch, so you have to sit. But now you're thinking, oh, you know what, what's that doing to my back?
Yeah, sitting is a new smoking. Like,
Right.
I'm doing this.
So now we have a biological of physical stagnation of I can't move around, right? So we might, just like we talked about earlier, we might get that signal of like, hey, move, please, it's a little achy. But then you have the social side of what have you read, what have you seen, what have you heard. Then that plays into your psychological side of what's going on, why do I feel what I feel. So once you feel that kind of initial ache, maybe you think of it much more than what you thought than what it actually is. So rather than just seeing it as a signal of, hey, maybe I should get up and go for a walk, you're thinking, oh, is that my, like, what I heard something about like how your discs don't like sitting and how it's too much pressure on them and how that leads to problems over time. I think that's finally catching up to me, and then you start Googling more.
Yeah.
And then you start running into more stuff. And then you order a scan. Then you actually see, because you're 50, and so 60% of people at 50 have disc bulges. And so you see one and you're like, there it was. I knew it the whole time. Google was right.
Yeah.
And that's when we start to link.
Boom. Yeah. And so we started going through this multitude of things that actually started the cascade into, we linked it to this one thing that may not even have like any relevance.
Yeah, I think just a very quick story on that. When you were sick, she was away in the summer, came back with whooping cough. Okay, she told me on the phone, I got whooping cough, and my initial thought was, I thought like whooping cough went out with like the plague. Like I thought it was, I thought it was like smallpox. So as we're talking, I googled just what whooping cough was. As soon as I read, we just spent that morning together doing it in a meeting, and I just read the first sentence, highly contagious. I instantly felt sick. I was like, whoa. I feel sick now. Like 8 seconds ago, I was 100% fine, and now I feel sick.
You're a terrible person. You got him sick. You made him psychologically sick.
Your brain screwed me. Like I was 5% more sick, having read 3 or 4 words on Google, and I was like, that's powerful. That's like to be influenced that quickly, to have such an intrinsic feeling of unwellness, having read the words highly contagious. I was like. And then I was like, I had to have a word at myself. I had to be like, you're not sick.
Yeah. Do you know, again, just to like reiterate, it just goes to show how powerful our mind is, and then how you really need to be careful what you feed it.
For sure.
You have to feed it some really good shit all the time.
For sure. And I think that, just to make sure that we're staying pretty grounded here, for the grand majority of people, there is probably going to be some sort of like biological trigger to the initial pain. Like it is probably going to have some sort of like increase in activity, or, that just, so what we say is that, you can break down how you like overload your system into like an acute overload, which is what we call all of our acute injuries. You have a fall, a 300-pound linebacker just barreled into your knee, right? Those are all of our acute injuries, car accidents. Then you have kind of your cumulative overload, what we call our overuse injuries. And you can say you were doing too much too soon, or too hard for too long. So you kind of that person who just literally just ran their recovery into the ground. Okay? So that could be the thing that is of where when somebody is like chronically stressed and they're just not sleeping well, they're not eating well, and they're traveling a lot, and then they're still trying to maybe work out as hard as they always have, and then they start feeling that ache, and they're like, yeah, nothing really has changed. And it's like, yeah, but you've literally been feeling like fatigued for the last 2 months, and you just kept going without resting, and here we are today. So I think that there is, for the grand majority of people, going to be some sort of like biological load factor that comes into it, and then I think the mind is a magnifier of that, right? Yeah. And so the mind can dial things up, dial things down very easily, depending on how you perceive.
And how do you? What are your thoughts on the term overtraining?
It's probably not going to happen for the everyday person going to the gym. So overtraining is a actual diagnosable condition, and typically you're going to need to 2 months off or of light work in order to come back from that. Most people are, whenever they talk about overtraining, are actually just overreaching.
Right.
So different terms. Overreaching is where you are feeling fatigued and you're seeing a bit of a performance decrease, right? And then we can say, is it functional or non-functional overreaching? So a functional overreaching is you're feeling fatigued, you've overloaded the system, so your performance is down. Maybe you just you feel slower, you feel more sluggish, whatever. But then you deload or you take a lighter session or something, and then all of a sudden your performance is going to spike up. Okay, it's because the body's going to recover, adapt to that stressor, and all of a sudden you're going to be really, really good. We actually can use that to our advantage. Non-functional would be, I'm just going to continue to run myself hard, to where if I'm not making progress, I should just go harder. If I'm not then making progress, I'm just going to go harder. And
this is something you see with elite athletes potentially, as opposed to the layman.
You can see this one in anybody.
Mm-hmm.
Yeah, overtraining that's the one that you might see in an elite athlete who has to do 2-a-days on the field and then has to hit weights and then has to prepare for games and is having to do this over the course of an 8-month season, and they're having to really go all the time. You might see that pop up in them, but the average person is not going to be stressing their body hard enough via physical activity in order to set that in.
Mm-hmm.
And is the functional overtraining? Are you tiptoeing around kind of a super compensation?
Yep, that's exactly what it is.
Yeah. Okay, cool.
So in a super to receive the super compensation effect, you have to overload the system to the point that you're carrying some fatigue through, and that you do need to reach that point where things feel a bit sluggish, things feel a bit heavy. You don't quite feel at 100%.
Yeah.
And that's when we should be kind of deloading down so that we come back stronger.
Yeah, cool. So then what language would you use, or what would you say to somebody who's like a full-time worker but also high-level kind of weekend warrior athlete, like a cyclist or a triathlete who is presenting with this mindset of perhaps I am overtraining?
I would be asking them, first, we try and dive into it of, okay, you're not progressing, right? So you're not progressing. That's our objective marker. You're not seeing improvements in your runs or your weights or whatever you're doing. You're not seeing improvements in your performance on your sports. And then we ask, how do you feel? So we need to put those two together. So if you're not improving and you're feeling like crap, then you're probably in that state where, taking a bit of a break, taking a bit of a rest, and improving the recovery would be the best option. Mm-hmm. On the flip side of that, you're not improving and you feel great, I feel wonderful. Maybe you probably just need to work harder.
Yeah.
you probably, because there is a minimum stimulus that's going to be needed.
Yeah.
And some people are just going to adapt to where some people are just going to continue to adapt to where the point that whatever you're doing is no longer enough and you're going to have to do more.
Yeah.
So, we have the two personality types of no pain, no gain, who's the person who's just going to just dig their hole. And then you have the person who will never push themselves hard enough to actually get stronger. Right? And either end of that can be a problem.
Mm-hmm.
Right? We're trying to find that sweet middle ground of, I understand that this is supposed to be hard. I understand that I'm supposed to feel a little bit fatigued every now and again, but I also understand I'm supposed to rest. Right?
Yeah.
Mm-hmm.
Cool. So I want to ask you one thing. I've seen it on your finger all weekend.
Yeah.
Talk to me a little bit about this ring, because I've seen one before.
We
Okay.
have just like gone from one topic to
Well,
another.
That's why we're here, right?
Amazing.
This is a Qualo ring, so it's just a silicone ring. Nothing special about it at all. Honestly, I know that there's some coming out, I think, that have like heartbeats.
Oh, it's
heart
not a
rate
biometric
sensors.
one.
No, there's no biometrics in it.
That's
It's
what I was
literally
asking.
a silicone ring. But funny story. So I got this like super nice ring whenever my wife and I got married. So it was this like patina copper and deer antler ring.
Oh,
like,
wow.
Just beautiful ring. But like working with patients, it would like scratch them.
Oh.
So and I just didn't want it to get. I didn't want it to get ruined. I didn't want them to like getting scratch marks and stuff on them. So my wife and I both got these rings, and I just this is what I travel with. I always leave the nice one at home and everything like that. And I actually haven't worn the nice one in so long now. Not but because this is just here. But yeah, there's nothing special about it.
So the reason why I asked is because there's these biometric rings. So, you know, like a Fitbit will record all of your data. Well, there's rings now that look
like
exactly like that, and it's measuring everything: heart rate, recovery.
wow.
This is what I was going to ask you about, but if it's not, if that's not what it is.
But you know, like you can get. But I think that having those things are pretty cool, though. Like having things to like track your steps and stuff like that. I mean, as much as like probably like the calorie counts and stuff like that are probably pretty inaccurate, they can be a good baseline measure for you to like measure one versus another. You know, whether it's saying that they're accurate or not. That stuff's pretty cool to have.
Do you use any?
I used to. Before Fitbit actually came out, I was probably into like the very first ones. So it used to be like this like strap that you would like wear around your tricep, like, and you could
Very
see it.
cool.
Yeah, super cool, right? And this wasn't long ago. This technology has really come along. Very quickly. This is back when I was in chiro school, so that was 2011. So I have one of those that would kind of like track calories, your calorie output, and I would use that to like track my calorie whenever I would track my calorie input and my Fitness Pal and all that stuff. And so yeah, I've had all that. Now I just kind of like have the step counter on my phone that it's like my measure of daily activity. Of, you know, I try and be somewhere between like 7,000-10,000 a day to make sure I'm not just sitting at my computer all day. But yeah, that's about all I use now.
One thing you just reminded me of when you mentioned chiro school, and you can maybe link it if not. Over the weekend, we spoke about the ritual of therapy and the ritualism of, and you had an interesting story about how you call your next patient into the room.
Yes. So the therapeutic ritual. So I do a huge section of the course on the contextual effects of treatment, and all these, and so we call them non-specific effects. And so the different features that go into things. So like his personality type plays into how he responds to a treatment. My personality type plays into how he responds to a treatment. Our relationship, you know, if he thinks I'm the world's largest asshole, he's not going to respond well to my treatment. Versus like if he thinks that.
Why are you laughing so much?
No, because I agree with you.
Yeah.
And actually, there's a lot of studies that say that if doctors spend 5 more minutes more with their patients have these massively positive outcomes. And they tested all of this. I don't remember the studies properly, but it was literally time. It was time.
So interesting one now. This one just came out. Was patients after surgery got put into 2 groups. One got an automated text service, and I mean this is like it's a robot texting them from the surgeon and from the surgeon's office, and the other group got nothing. The group that got the automated text service, they said they felt their surgeon was encouraging them more through their rehab. They felt that they were more adherent to their exercise. They felt better and had better outcomes than the group that didn't. And this is just a robot texting them to say stuff like, "Hey, pain 2 days after surgery is pretty normal. Don't freak out if you feel that." Like, oh, okay, yeah, because I have been feeling that, so now I have clarity.
Wow.
That kind of stuff.
Wow.
Yeah.
Like it just is. It's like a control factor, right? So, like that's how easy it can be to implement some stuff. It's like basic caring nature helps. But also stuff like, when a patient feels like their doctor cares for them, they get better outcomes. So back to therapeutic ritual. Back to therapeutic ritual. So treatment effect. So we see that when a treatment is like seen as more like cutting edge, or it's new, it's a branded technique over a generic technique, it's thought to work better, and it gets better outcomes via higher what we call placebo effect or contextual effect. So think about like your off-brand medication versus your brand name medication over the counter, right? You look at the ingredients, they're exactly the same. But people still buy the brand one thinking it works better. So whenever I approach a patient, we're going out to get a patient, then we might have like an iPad in our hand, and we just walk out with the iPad, whether the screen's on or not. And you just look down there and you look at the patient's, and you look down and then you call the patient's name. It looks like you're like, I'm ready to, hey, John, really can't wait to help you out with your shoulder today. Like, come on back. And because maybe you looked at their file an hour ago, because everything's online now. We have all these electronic health records to where, you don't necessarily need a full paper file to walk out with for a patient. So maybe we walk out with just a file of blank paper, open it up, look down at it, look up, call that patient's name, and just like say like, hey, can't wait to work with you today. I'm Dr. Harden. Because what it does is it just sets this thought of like, oh, they looked over my stuff. Versus they didn't see me look over their stuff an hour ago on
and
my
just
computer.
like come in.
They don't know, right? Now they're like, oh, look, he has my file, he has my stuff, and he's like, he's helping me, like he cares. They actually, and it sets you off on that right foot. So that's part of that doctor-patient relationship. Where ritual comes into it is it's the show that goes into the treatment. So think about that think about surgery, right? Surgery has a huge ritual to it. You're given your anesthesia, you're put in, you're gowned up, you have the nurses, you have the surgeons, everybody's having to wash in. Like there's a lot that goes on for surgery. It's a huge ritual. And so that makes you think, oh, something definitely happened. Something definitely must have changed with this. So from a chiropractic perspective, we see a lot of patients that have you ever been adjusted? Okay.
Loads. I love it.
So have you ever had the chiro adjust you and then you didn't hear the sound?
Yeah.
It doesn't feel as good, does it?
No, at all, actually.
It works the exact same.
Yeah. Do you know sometimes when she does my jaw, she puts on a little glove and puts her hand in and just like massages stuff. And I'm like, ugh, this is nothing. Go somewhere else. Like, do my neck, please.
Right. So we see this all the time, though, is that whenever so the adjustment is not us moving bones. We don't move bones at all. We provide a little like rapid stretch to everything around it. It stimulates a bunch of mechanoreceptors there, and it's all like a neurological effect, basically. So, and the sound is just from that stretch, a little gas leaves the joint, and you hear the pop. So, all that happens whether you hear it or not. But when you hear it, it feels better.
Yeah, instantly.
Yeah.
Like sometimes I get like my thoracic spine adjusted, and when the whole thing goes, I'm just like, I feel release. Yeah, release. For sure. Total release.
Well,
oh my God, is that a placebo? No.
I don't want to kill the placebo for you. It obviously still feels good. And
well, it still feels good.
So here's the interesting part, though. You can know it's a placebo, and it can still work for you.
Amazing. I love it.
Like,
I'm keeping it.
I could come over there and adjust your neck right now. You know it. And it would probably still feel better to you if you heard the sound versus not hearing the sound. Okay, like it just works that way in some cases. So, and that's where we see things like sometimes like in a lot of studies, chiropractic adjustments don't outperform placebo. Okay, because a lot of it is very contextual. So we need to think about that in terms of what all actually goes into the treatment you're performing. So
So are you doing a lot of little placebo effects and magic tricks and stuff?
well,
I'm
of
just
it,
kidding.
some of it is. I mean, some of it is. So and it happens in exercise.
Mm-hmm.
Like, I mean, exercise is certainly not, immune to this. To
Yeah.
where if we're having you do a lunge, and we
Mm.
say, hey, try keeping your knee back, more of a vertical shin, that's going to load your hip more, and it's going to take stress off your knee. That's partly a placebo effect.
Mm.
Now, it is biomechanically less stress on the knee, but I have started to condition you to believe that it's less stress on your knee, therefore should not hurt as much.
Is that memetics? Have you ever heard
I
that
don't
term?
know.
So I read a book a very, very long time ago, and it was talking about the study of spreading an idea from one person to the other. And they called it the study of memetics, like a meme. And it was sometimes that idea can be a positive idea or it can be a negative idea. And the negative ones he akin to being like a virus. So I can give you something, an idea, and it can be true or not true, and you can continue to spread that idea.
We call that nocebo.
Ah.
Placebo and nocebo. Nocebo
Interesting.
is basically a negative effect placebo.
Mm-hmm.
So so it's interesting. Like if I were to tell you keep your knee back, that's gonna be a lot more stress on your knee. It's likely to hurt. If we do that, I might be able to override the biomechanical effect and make that hurt, even though it's less biomechanical stress.
Just like when people leave a doctor's office and they say, "Oh, you can never do a squat, or you can never do a deadlift, or you should never run."
That's bad for your back.
Yeah.
Yeah.
Okay.
So that's nocebo.
Got it. Mm-hmm.
Telling someone, oh, all your pain is just because you're weak. All your pain is just because you have that leg length difference, or your feet are flat, or yada 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 yada.
Knees above the toes.
Knees bound in your
forward,
toes. Yeah. All that stuff is kind of a nocebic response. Not to everyone, but to some people it will be, to say, oh, damn it, like I have flat feet. Do I have foot pain? Should I have foot pain? Should I run that marathon? I don't know if I should run that 5K. Like, I don't know what I should do now, right? And so then once they do it, and as I said, like, I think there is for most people going to be that biological trigger, right? I think that if maybe that they won't just feel pain because they have flat feet and they were told people with flat feet get foot pain. But if they then went and increased their activity, maybe they don't have as much wiggle room to increase their activity without feeling pain because of the psychological magnifier that we put in their brain.
Yeah. I loved what you said before, the metaphor of the mind being the magnifier or the diminisher of something. I really like that, just went ding in my mind.
Yeah.
It resonates.
It's amazing, what can happen. We see extreme cases of it, obviously, where people can, severely magnify or diminish how they feel, and a lot of times it might be just maybe 2-3 points on a pain scale, but that's significant for somebody, and I think it goes beyond just how you feel. It goes into how stressed are you, what's the anxiety levels like around it. Like, it's going to have more repercussion beyond just like, yeah, like my knee pain's still there, but I'm more chill about that, and that's a good thing too.
Cool. Well, we really appreciate you coming on.
I know there were so many like little nuggets of gold for me. I think one of the main things that hopefully people can take away from this is really that, like, learning and understanding their own process and being able to kind of understand, okay, I'm not going to be attached to this. This might not just be like my pain here because I have a back problem. It could be so many other facets. And if people walk away at least acknowledging those things and then being able to address, oh, maybe I need to be less stressed or eat better or some other facet, and they could get better and diminish their pain, then amazing.
Yeah, I think if we take a very take a very reasonable approach to most things, of don't do too much too soon, don't run yourself into the ground, right? That's like the number one things that you can do to just kind of just stay healthy, right? Make sure you're sleeping, eating, all that stuff like we should be. But then realize pain is normal. Like, we're all going to feel it. Like, pain's just part of a human experience, right? It's not bad. It's just there. It's just part of it. So don't freak out about it whenever you have it. Treat more of your pain like a paper cut Like, try and find some clarity there. And even if you don't necessarily have clarity, trust in the process of, if I just kind of just, maybe back off of things that hurt me right now, maybe modify my activities a little bit so that I'm not, pushing myself into that pain trigger all the time, but then just kind of gradually work my way backwards. It doesn't mean that I have to necessarily limit myself from any crazy activity, because I'm not breaking my back, right? I'm super resilient. I'm super adaptive. I'm super strong, right? That I am a human being. And if a little thing like a disc bulge could end the human race, we wouldn't have made it this far.
Yeah.
Mm-hmm.
Yeah.
Like, we wouldn't be here. So
yeah, I tell people all the time, like,
get that.
if you think that like bringing your leg across your body in a stretch is bad for your back, if you think your body is so like feeble, it's not the case. We're way more robust than people give ourselves credit for.
Yeah, we just wouldn't have made it here.
At all, especially like with natural selection. Earth would have gone, see ya.
Yeah, you're done.
Yeah.
Yeah.
You're done.
Over.
Yeah, you're much stronger than you think you are, and just realize that you're not as broken as you think you are either.
Mm-hmm.
So keep that mindset towards it of acknowledging where you are at, but just not hanging on it as a crutch for why you can't move forward. Realize that you can acknowledge where you're at, and you can be injured, and you can acknowledge your injury and still say, I can move forward off of this to where I want to go. And then you're just going to buy into the next baby step in front of you, no matter how small that is.
I also think as well, helping people understand, well, this helped me, so maybe it might help others, that whatever it is that's happening can also be something that you learn from, and that you can use that to move to the next place, because you have that like little nugget of knowledge, and that can actually be a stepping stone in itself.
For sure.
Does that make sense?
Yeah.
Cool. Well, look, we won't take up any more of your time. Really appreciate you taking time to come and speak to us.
Well, thank you guys.
It's an absolute pleasure to find you. Are one of my idols online, so it's an honor for me.
Yeah, he's
to meet
actually not lying. He like he really does.
I really
know
appreciate
you.
it, man.
He's been stalking you for years.
Yeah, guilty.
Sit
Yeah.
over here now.
Yeah. Well, look, thanks a lot. Just remind anybody who doesn't actually know where they can find you online, how they can follow your stuff.
So my name is Dr. Jacob Harden on just about every social outlet you can find. So my main one is Instagram, dr.jacob.harden. You'll see my bright smiling face there on my profile picture. On Facebook as well, on YouTube, and now right here with you guys on this podcast.
Awesome. And then where can people get info on the Prehab 101 course?
So there it's Linktree/Prehab 101.
Okay, cool. And your next course is in Kuwait?
My next course is in Kuwait. Then we're off to Australia for all of March. Coming. Yeah.
I'm going to be in Australia in March.
When are you going to be there?
In Sydney.
Yeah.
Like on Friday. I'll be there on Friday.
Nice. How long are you staying?
Till March the 3rd.
Okay, so we'll be coming in on the 6th.
Oh, shame.
Yeah.
We'll miss each other.
We'll just miss you.
Mhm.
Yeah.
Will that be your first time in Australia?
It will be.
You're going to love it.
Yeah. I can't wait. I've been looking forward to this for a long time.
I know. I'm really happy for you.
Yeah. So we're going to do Australia. Then we're going, coming back over
What are the
to
dates in Australia you doing?
Brisbane. We're there on it's very early in the month, like 8th, 9th, somewhere around in that time frame, whatever that weekend is. Then we go to Sydney the next weekend. We're actually doing 2 courses there. Then we'll go to Melbourne on the, I think, 25th, 26th. So come back. We'll be in Canada off of that. Then go over to the UK and do London and Dublin again in May.
Amazing.
And then I'll be in the States for most of the year after that. So I'm kind of getting all my international stuff early.
Awesome. Well, I definitely recommend everybody in those cities get yourself on that course, because you're going to learn a huge amount. Mindset, psychology, practical exercises. It's fantastic. Really, really great course. So thanks a lot again. And next time you're in Dubai, be sure to give us a shout. We'll catch up with you then.
For sure.
All right, thanks. Cheers, guys.
Bye, guys.